topics that they've submitted, and we answer the questions. But actually, this one's a little unique because some of you may know, if you're in our CCO club, that my 7th grandbaby was born on Friday. So I'm so excited about that. And so technically, even though we have labor and delivery codes and questions that come in, I decided to kind of tweak it, and I changed it to labor and delivery coding tips. So it's not a specific question that I'm going to answer. I just decided that it would be good to give you some tips on coding for labor and delivery. This is all on the tip of my little gray cells. I was thinking about it a lot when we got to experience that. And this is my number one child, my son. It's his number one first child. So they let me be in the room, which was so exciting. And again, you are right. My coding little brain was going crazy. I came up with some really, really good tips. I came up with 10. I was scrambling to come up with 10 because I had 9, and then I saw another one at the last minute that I knew you guys would really like. So if you notice that the font's a little bit different, it's because I got it off of a fabulous AHIMA article. All of the things that we talk about on the slide deck tonight, there is links on how to go and view that information, where I pulled the content from. And I want to just do a special shout out to a Dr. Ramir that I pulled fabulous content from, absolutely fabulous. So not only did I put the link for the article that she wrote, but also her bio is there on the resources. Take some time and go in there and look at that. I believe she does emergency medicine, but she's also a CDI and specialist with ICD-10, and her article was fabulous. So you'll see in the slide deck, many times I say per Dr. Ramir, and these are things that she stated in the article, and they're fabulous tips. So we're not going to talk about things that are everyday stuff you learn for OBGYN and gynecology in general, because that is such a broad area. Instead, out of these 3 articles that I read, I pulled specific things that we don't talk about very much, that ends up being problematic for us as coders and auditors. So again, that's what this is about. We've got 10 tips that you just need to be aware of, pretty much. And the first one we're going to talk about tonight is that every time you have a patient that comes in that is pregnant, the pregnancy, there will be an O code associated with it. Doesn't matter, predominantly, doesn't matter what they came in for, there's going to be an O code associated with it. Now, as you know, that's chapter 15, which I don't like to think about the chapters. That's not the way my brain works. It is with ICD-10, I always think of the first character. And so it's a letter. And anytime we're dealing with pregnancy, it's an O. And we think of that as obstetrics. It's very easy to remember. Now, this is one of the things that Dr. Erica Ramir said, and I hope that I'm doing justice to her last name. I would feel very bad if it's pronounced differently. So forgive me, doctor, if you do end up seeing this or someone that knows her. So the very first tip is the most important thing. If she's pregnant and in the hospital, the primary diagnosis will most likely be complication of or complicating. Now, if we just have a normal delivery, that's different. We're just going to have an O80, et cetera, et cetera. But we're talking about if we have a patient that is pregnant and in the hospital, then, and it's not because she's delivering, then it's going to be a complication or complicating the pregnancy. Okay, a complication of. Now, With inpatient, we call that a primary diagnosis, and they abbreviate it PD. So you can be in the hospital for something completely unrelated to the pregnancy, but you're going to be very hard pressed to find anything that is going to result in needing to be in the hospital, whether observation or not, and the mother's pregnant, and it's not going to complicate the pregnancy in some way. Okay, that's why, if you think about it, if you're pregnant and you go to a dentist, they don't like to work on you because it could complicate the pregnancy. Right? There's a lot of chiropractors don't want to adjust women who are pregnant. Now, there's a lot that do that specialize in that, and they get a lot of. I know my number 2 child, she has 5 children, and she often, when pregnant, goes to the chiropractor and gets adjustments, and it really helps. And her chiropractor specializes in that. And so, again, if you fall down and break your ankle and you're pregnant, there's going to be a complication of some kind. Why? Because maybe you have to have pain medication. That's going to complicate the pregnancy. The provider's got to think about what medication you can and cannot be given while you're pregnant. Or what if you have to go in and have surgery? What if they have to put pins in your ankle and you're pregnant? Well, anesthesiologist is going to, no, they don't want to do that. And let alone the orthopedist isn't going to want to mess with somebody that is pregnant. So again, very, very often you will see a code for complication or complicating. And I love the comment that she made that says, I cannot recall a single patient who went on to deliver during an admission whose primary diagnosis was not a complication of or complicating the pregnancy. So keep that in mind. Now, this is an example that she gave. She said, we have a patient's 3rd trimester who's in an MVA, and they go into the hospital, they're in observation, and then they went on to deliver. Now, again, we're talking about labor and delivery. We're not talking about somebody that comes in that's in a pregnant moving vehicle accident and they discharge them home without delivery. That's pertinent. We're talking about labor and delivery stuff today. So if that occurs, they deliver, then you're going to see an O9A code. Injury, poisoning, and other consequences, external causes complicating childbirth. So if this is not a code that you're aware of, O9A.22, take some time to go look at that code. Write that down in your notebook. Become familiar with it. Look at the guidelines that surround this code. Okay, and the key is that the patient's been in a motor vehicle accident and their observation, but they went on to deliver. Okay, so what are we going to use as a code? O9A.22. Now, whenever you have any reason that the patient's injured, you're also going to need to code the outcome of a delivery as well, and how many weeks gestation. Now, that is stuff we're not going to really talk about tonight, because that's stuff that's basic information that you get when you learn to code anything that's an O code. Okay, and whenever you bring up an O code, it's almost always listed there in your encoder, and it's all over your ICT manual, where it says, make sure you code the outcome delivery and how many weeks gestation. Okay, and then it gives you a little graphic to show you how many weeks gestation is, et cetera, et cetera. Okay, so we're not going to talk about that. So tip 1, know that if you have a mother that comes in, there is a possibility, if she's not there, if there's been some kind of an accident, an injury, poisoning, right, then we want to make sure that O9A code is appended. Don't leave it off. Tip number 2, if you don't find an O code, look here. So let's say you're looking around and you're in the index and you're even looking in the tab, you're like, I can't find a code for this. So what do I do? Well, there's a great little area in the O codes that are other obstetric conditions not elsewhere classified NEC. This is going to be 094 through 09A. So I would also like for you to take your notebook and make a little note of that. You need to pay attention to those other codes. And we know what other code means. Other means we're going to have an O code. No matter what happens to the patient, it's going to be appended. But if we have some conditions that are a problem, then we want to look at 094 through 09A. And then Dr. Amir gave some great examples that I want to just bring up. Viral hepatitis, malnutrition, and there's a whole bunch of information on malnutrition and gestational weeks. Let's see, obesity. We overlook obesity. That complicates pregnancy, and we'll probably have a BMI. Now, just like everything else that rules coding BMIs, we still have to have a diagnosis of obesity to code a BMI. Acute asthma attack, appendicitis, cancer even, but those are all covered, right? We have codes that we can go look over there. However, she states, and I thought this was really pertinent, that in her reviewing of charts as a CDI, solidary code for anemia. And then, for example, D50.9, iron deficiency anemia, unspecified. She said, I knew a code was missing. And so if you have a D50.9 on an obstetrics patient, then you better be coding 099.02, anemia complicating childbirth. Now, of course, we're talking about labor and delivery. We're not complicating the pregnancy, we're complicating the childbirth. This is a code that gets overlooked again and again. So make a note of 099.02, read the guidelines surrounding it. We know as coders and as an educator for coders, anemia, there's just pages and pages of anemia and guidelines that surround anemia and everything. So again, pay particular attention to that code. If you have a condition, if they say the person has, appendicitis, we're going to find something in the digestive system and everything. But anemia, very often overlooked. So I really appreciate the doctor bringing that up. We are ready for tip 3. If you are in labor and delivery, you will know what SROM stands for. That is spontaneous rupture of membranes. So in other words, your water breaks. So my daughter-in-law had for the last few weeks just knew that her water was going to break when she was out and about. She even stopped working because a week early because her job was a very physical job, and she was so scared that her water was going to break while she was in the middle of working. And we told the old wives' tale, well, you're supposed to carry a jar of pickles with you wherever you go, and that way if your water breaks, you just drop that jar of pickles, and everybody thinks that's why there's a puddle on the floor, right? Which I'm sure you guys have probably heard that. So SROM, spontaneous rupture of membranes, your water breaks. And be aware of that. Now, POAN is present on admission indicator, no. So was this present on admission? Yes or no? Okay. So what happens if we have a patient whose water breaks, labor starts, and there's no complications? Then that's our fabulous 080 code. We came in, full turn, uncomplicated delivery, everything was honky-dory, no problems whatsoever, right? And that is one of the most common codes that you're going to see if there's no complications. However, what happens if you had SROM, okay, full term with an onset of spontaneous labor with a complication? There's not really a code for that per se. So what do we got to do, right? Well, the answer is we're going to code for the complication as the primary diagnosis. Why is the person there? Because there's a complication. Now, I could list off all kinds of complications and stuff like that, but keep in mind, this is, you've got your spontaneous rupture of membrane, so your patient's water broke. She is going to, she has a complication, and it could be list a number of things, and she delivers vaginally. Then you're going to go ahead and code the complication. Usually it's going to be your primary. Okay, but what happens if we have a C-section? That's a little bit different. Now, we do have codes for C-sections too. So again, we do so many C-sections now, so it's either going to be a vaginal delivery or a C-section. Okay, so you learn all about that when you're learning to do your O codes, so we won't go into that. However, if this happens, we have the spontaneous rupture of membranes, we have onset of spontaneous labor. Okay, that happens, and we have a complication, and there is the result of the delivery is a C-section. Then what we're going to do is we're going to code either the complication, just like we would with the vaginal birth, or the reason why the patient had to have a C-section. Either way there, you have to be really, really careful. And Dr. Amir makes a point to talk about some of the documentation that they need and how it needs to be very, very clear with C-sections. Okay, so again, take time to read her article and reiterate those things that we're talking about here. So again, just to review, water breaks, we go into labor, but there's a complication. Okay, primary diagnosis, if we deliver vaginally, is the complication, but if there's a C-section, you can do the complication or why we ended up doing the C-section. And there's all kinds of reasons why you could do a C-section, and hopefully it is not because we had to go in early because our OBGYN was going to go on vacation, right? That's not going to work. You know that happens though. Okay, number 4, our tip number 4. We need to define preterm labor. Now this gets confusing, and let me show you why. So back in 2013, the ACOG comes out and says that maternal fetal medicine has redefined full term to reflect improved neonatal outcomes. These are the definitions. So if you're preterm, you're before 37 weeks. Okay. If you're early term, you're between 37 weeks to 38 and 6 and 7 days is what that is. Okay, full term is anything 39 to 40 weeks, late term is 41 weeks, and post term is 42 weeks. That's their definition. Now, this is the definition that all the obstetricians go by because it is the ACOG. So this is the protocol. This is that's official. Okay, and so that's the way they're going to document it. However, that's not really the way our code book works, and it hasn't caught up yet. So Dr. Amir said, this is where we get into some complications. When you look in the tabular, you have a list before 37 completed weeks of gestation, and they could infer post-term because it has a parenthetical clause of 40 to 42 weeks in the index. This can be extremely confusing. Okay, but even if you figure it out, all right, and ultimately what will happen, so that if you're new to labor and delivery coding and obstetrics, don't worry, you have cheat sheets and stuff like that, and you have a protocol, and your compliance officers, your compliance team has said, okay, when this scenario happens, this is how we're going to code it, okay? So don't freak out. But when you are looking at this, there is a disconnect. And she goes on to say, this is why we have to be careful because of the DRGs. Okay, now, again, we code for statistical purposes, and you hear me say this all the time till I'm blue in the face. However, it's a convenient way to get paid. So the DRGs are extremely important, okay? So if you use 048.0 post-term excuse me, post-term pregnancy, okay, if that's the reason that your patient is admitted and you have additional diagnoses and stuff, then you risk adjust the DRG. But now, if the patient is considered late term and you have diagnoses and so on, the primary diagnosis may be no comorbid condition to change the severity of the illness, okay? So again, we can have some problems with the DRGs if we don't have a thorough definition. This is really going to have to be reflected by the documentation. And this is where our CDI people come in and our auditors, and they communicate with the providers. Hey, we've got to have this spelled out, because not only do we want to get statistically right, but we got to make sure our DRGs are, we're getting paid for the work that's being done and the risk that's done for the patient. Okay, we're halfway there. Now we're to tip number 5, and it goes into preterm labor. So if we've just identified that, hey, preterm is something that we want to be aware of, then in the index, this is what it looks like. So if both of these are for preterm labor. If they're in their second trimester, now we don't have to talk about that because that's in your index, that's in the tabular, and if you don't have to have it memorized, but if you do labor and delivery, you're going to have it memorized within no time. So second trimester with preterm delivery, then you have to think, is it second trimester or third trimester? And then you've got your 060 codes. And again, it's super simple because it's 0.12 for second trimester and 0.13 for third trimester. Now, if we deliver with a term delivery, then it's 060.22. Without delivery, we're going to be using 060.02. Now, preterm labor means we've gone into labor before we're ready to deliver that baby. The baby's before 37 weeks. We want to keep the baby in there to gestate a little bit longer, to bake a little bit longer. Now, Boyd said before we got started, he goes, I bet you got lots of stories to tell because of the baby being born. Yes, I do. So my little grandbaby was 8 pounds and 15 ounces, and he was 22 inches long, and he was almost 2 weeks early. So they induced her. Why? Because he was right at 9 pounds, and she had a little bit of problems with her sugar, which promotes big babies. I thought for sure we'd have one of those babies with all the big fat rolls, but no. But if we had not had her induced, then yes, we probably would have had a very portly, chunky little baby. Because that's what happens with diabetes. Nope, just a big baby. So if we have preterm labor and we deliver, we've got 060.22. But if we stop the labor, we manage to give them medication and we're able to back the labor off, right? And a lot of times they start giving medications to develop the baby's lungs and everything if they know they're going to be early. And so you'll see that stuff in the documentation to indicate, hey, we're going to try to stop the preterm labor, or we're just going to have to let it happen. Now, going back to preterm labor, that means you need to know, is it third trimester? Also, if we're not the second trimester, then we're the third trimester, and then they get into delivery or without delivery. So preterm labor, but we're in the third trimester. So that tells us how many weeks we are, right? Because we just talked about that in the previous tip. Okay. And again, if these are unfamiliar to you, the preterm labor terms, I would encourage you to go and look at reasons why women go into preterm labor. Now, there can be lots and lots of reasons, but what are some of the more common ones? What do they do to help prevent preterm labor when it starts? What do they do to stop it? What are the documentations, the things that you're going to see, the medications and stuff that you're going to see that if they to stop it, or if they don't stop it, what they do to help the baby develop very, very quickly. So just increase your knowledge base. Good idea, right? Tip number 6, there's no limit to complications. Now, Dr. Amir went on to say that once the patient begins labor, complicating conditions can arise. Okay, you could have no problems at all, and then you can have a complicating condition show up. But it may not just be one, it might be multiple. And so you have to remember there is no limit. We could have 5, we could have 2, we could have 1, we could have 6, right? And they all need to be listed. Okay, and we need to have them listed for statistical purposes, but we also need them just in case we end up having to do a cesarean section, right, because of a complication. And so make sure that that when if you have to do education for your provider to help translate, to give them the options, hey, these are the codes that we're limited to, they need to make sure that their documentations of the complication is in a codable format, meaning the verbiage needs to be similar. We need to know which was the complication out of the 3 complications that was the reason why the cesarean was performed. Okay, they don't want to be queried, so if we know that ahead of time. Now, this is something that you can work with as the coder, maybe if you're CDI or the auditor, or you're just having meetings for compliance with your providers, and make it easier on all of you guys. Have conversations about this and how it's helpful. All right, tip number 6. Oh, well, we're still going on with that. I forgot. She gave 2 excellent illustrations. So we have no limit of complications. She gave 2 that are examples that she sees often that you have to pay attention to, and the documentation is so important. So if we have arrest of labor, okay, so is it going to be documented as arrest of labor, or that doesn't mean that it's a transverse arrest? Okay, so it could be an O64.0, obstructed labor due to incomplete rotation of fetal head, right? We can't just have transverse arrest or arrest of labor. We need to know, was it the rotation of the baby's head? Because when they come out, the baby's head turns, okay? And they're often face down, and then as the baby starts to finish coming out, it rotates with the face up. And there's reasons, there is all different verbiage for when the baby comes out, if it's face to the side, so on. As far as also with the face up, the face down, there's so many different things, and that's just reading that you need to know to educate yourself and bring your knowledge base up. So is it an O64.0 or O63.0, prolonged first stage of labor? That's an arrest of labor. Or is it O63.1, prolonged second stage of labor? And my daughter-in-law had that O63.0 because they induced her, and they started at 5 o'clock in the morning on Thursday, and by midnight she still had not progressed past a 4, and so they gave her a break and let her stop, and they started her back up at 4 o'clock in the morning. Okay, now this is another one that was really interesting. It's a term that you need to be aware of. I went ahead and put the phonetic or the pronunciation of it. It's pronounced chromoamniotic. Excuse me, now I said it wrong. Chromoamn. Oh golly. I usually have the little hyphens. I even practiced it like 3 times before I came on. Chorioamnionitis. I said it so good. I hate it when I do that. Anyway, ultimately what we've got is a baby that the amniotic fluid, there's bacteria in the amniotic fluid, and this is going to happen before or during labor, where an infection is seen, and it can cause preterm labor, but it can also cause a serious infection with the mother and the baby. So if they have any type of an infection, then they're going to absolutely onboard antibiotics. This is also something that's very trimester specific. Do they realize that they have an infection in first, second, or third trimester? We need to make sure that all of this is spelled out, and we need to know if it does result in a specific infection. Then of course we would code that. Okay, we have to have all of that information spelled out for us. Now we're moving on to tip number 7. This is something you may or may not be aware of. What happens when we have a breech presentation? Okay, do we code it as maternal care code or obstructed labor? Because there's 2 codes and they read almost exactly the same. So what's the difference between 032.1 and 064.1? Well, there's a big difference. Okay, if it states that it's maternal care code, then that means that it presents prior without impact to labor and delivery. Okay, presented prior without impact to labor and delivery. However, if it's obstructed labor, then it exists and it impairs labor and delivery. Okay, that's your difference. They're both O codes. One is this is affecting the mother, but it's not going to impact, it doesn't affect the labor and delivery. And then obstructed is, yeah, it exists. We've got breach, but it also impairs the labor and delivery. But notice here are we've got the same buttocks presentation, complete, and frank breach, the same for both. And it could be it would be very easy for us to code the wrong one unless we have proper documentation that states, because when we see breach, what do we automatically think? Uh-oh, that's a red flag. And if you go in and you do a search on breach in the index, then you may end up with it being this obstructed. But if it really doesn't complicate the labor and delivery, then it's a maternal care code. We're just taking care of the mother. But if it obstructs the labor, then it's an obstruction code. Okay, make sure you make a note of that and you understand the difference between the two. Okay, then Dr. Amir also gave this great tip, and I thought this was really, really good because it also affects risk adjustment. So, of course, my little risk adjustment spidey senses went up. And she had said the commonly missed risk adjusted factor is ABLA, acute blood loss anemia. So what happens is when they're coming up with a reason for the CMI or the case mix index, and it was really low compared to others, the underlying cause usually is that we have an ABLA. And when she was doing education and doing CDI work, she said the chair told her all our patients have ABLA. Yeah. And she goes, I emphatically agree. Yeah, they have acute blood loss anemia. Okay. Now, she recommended to use a combined threshold of EBL, estimated blood loss, and a drop in hematocrit, as well as document the treatment or monitoring of the ABLA. That's proper documentation to say, yeah, we justify that our mother had acute blood loss anemia. How come? Because we had documented the estimated blood loss and the drop in hematocrit. Okay. Now, this is something that risk adjusts. We need this in the case mix, and we need this for statistical purposes, because if something comes out or a protocol happens, or maybe there's a new device or something that we can do to assist in not having ABLA with delivery, then that's fabulous. And how that's not going to be on anybody's radar if it's not properly documented and captured by our codes, because we code for statistics. Okay, so this is really impactful. This was probably my favorite tip out of all the ones that when I was doing the research. Now, it said also, she went on to say, now, if we're not going to do transfusion, then you might also indicate that, hey, we're going to have our patient go on iron therapy and repeat the hemoglobin and hematocrit levels. But she said, really what we've got to do is we've got to educate that sustaining ABLA is not a patient safety indicator. It was sufficient to change behavior and improve CMI. So again, we want the outcome to be positive, and that's where we get into the statistics. Okay, so again, that's my favorite tip number 8. Now, I not only love ICD-10 CM, but I love PCS. So I had to throw some PCS information in there for a tip. If you're coding inpatient, and of course we are, the one tip that is really, really pertinent is that you need to understand that products of conception means the baby itself. Okay, this is something that whenever I do any type of lecture with PCS, I usually bring this up. I like to do a lot of education on root operations with PCS, because if you understand the root operations, everything else just kind of falls into place. It's so much easier to use in CPT. In fact, it's brilliant. It's a brilliant code set. And I foresee it replacing CPT eventually because it's so good. But one of the founding things that you need to know is that you're going to see in the code set, the description again and again and again, product of conception, product of conception. And what does that mean? It means the baby. Okay. Now, another tip in part of this is that it is in anytime we do a procedure on the baby, they're going to be included in the obstetrics section. Now, we don't usually do that with CPT because we have P codes, right? So if you do a procedure and you have a pregnant female, other than products of succession, you're going to code to the med surge. Okay, so if we're not doing anything to the baby, we're going to do med surge, which is our largest area in PCS, whereas obstetrics is much smaller section. Products of conception is the baby. The example that I pulled out, and this came from a HEMA, and they're fabulous with PCS training. It says, pay attention to manually assisted delivery with mid forceps, and low cervical cesarean section. These are codes that are done on the products of conception. And then on a pregnant female, notice that these are, first of all, when your code starts with a 1, that's obstetrics in PCS. When it starts with an O, that's med surge. So if we're doing something to our female, okay, that's pregnant, if we repair a vaginal laceration, okay, that's an O code. Episiotomy, episoraphy, or raphy, episioraphy. So again, these are things that you notice, completely different area. We have 1 is going to be on the products of conception, the baby, and then these other codes are actually being done on the mother, right? Med surge. That's different. Right. Now we're at our final tip, and I went ahead and pulled this one because it came, an article I read in HEMA brought this up, and I thought, you know what, this is really important. We started noticing when we went to ICD-10 that whenever you bring up almost any code, they're going to ask you, is there alcohol or tobacco use, present? Now, why are we doing that? Well, because statistical purposes, right? And because it's going to change the way we treat and what we do for the patient. It sets up protocols to have this documented. And we know that alcohol and tobacco affect a person, no matter what their diagnosis is. If they are use and abuse of alcohol or tobacco is going to need to be reflected in their treatments, right? The provider needs to know. And if they go to another provider, they need to know. So we need this information captured. And with our ICD-10-CM codes, you're going to use the category 099.3 1, which is going to say, for example, alcohol use complicating pregnancy, childbirth, and the puerperium. You're going to assign for any pregnancy case when a mother uses alcohol. Now, you would use a secondary F code, one of your F10 codes, because that's going to tell us if the patient has a disorder. So our 099 code, because we're going to always have an O code if we have a pregnant mama, right? And if she uses alcohol, we're going to use 099.31. Now, there are codes for tobacco as well, but an F10 will tell us, well, what's the extent of the use? Is it use abuse, right, etc. And a great example that Ahima gave in that article, the scenario shows how you would use both of tobacco and or use two codes. We have pregnancy delivered at 39 weeks of gestation, single live born, alcohol abuse, right? So our first code is our 099.314, alcohol use complicating childbirth, right? Because the O code, what did we already say in our tips? Complication is a primary diagnosis. Then that code is going to tell you, hey, we need an F code. We need to know exactly what was a higher definition of the alcohol use, and they used F1010 for alcohol abuse uncomplicated. And then what's the outcome of delivery? Single live born, Z37.0. And then we have the weeks of gestation, the Z3A.39. Now, we didn't talk about in the tips, single live born and weeks of gestation, because that is just basic knowledge that you learn when you're going to be dealing with O codes. That's one of the first things they start teaching you. But notice our format, right? We don't have an 080 code because we have a complication. And that complication is alcohol use, right? It's complicated the pregnancy or the childbirth, excuse me. So our 099.314 is our first code. Now, there are other types of complications. So take time as we wrap up to go through and look at the complicating codes for childbirth. Familiarize yourself with them, because another thing I'm always saying, you don't know to code them if you don't realize there's a code for it, right? You need to be familiar with that. So did we have any questions come through? I am not seeing any, and that tells me I feel like I explained these tips well enough. But if you do tonight wake up and think, oh, no, I have a question, no problem. Just go to the CCO Club. It's cco.us/club. And we have a forum where you can go in and ask those questions. And I would love to hear both questions and scenarios that you may have experienced to help code them. We'll come up with some more examples and scenarios to code together in a later time. All right. All right, guys. Well, thank you very much. And let me just show you real quick before we close. Let me get my cursor over here. I wanted to give you, this is the resources that I use, the Ahima stuff, and there is the information on Dr. Ramir. And again, I hope I pronounce her name correctly. Fabulous article, and I look forward to reading more things that she wrote because it was brilliant stuff. Numerous articles, and a co-host of Talk 10 Tuesday. So I'm looking forward to finding that. All right. Thank you, guys. And don't forget to go out to the CCO Club.